I still don't see Alpha. I see him now.
Thank you.
I made you co-host, Alpha.
Thank you. Hi, everyone.
Okay. Welcome, everybody. Welcome to the webinar series hosted by the Center for Oral Disease Prevention and Population Health Research. The webinar today will be discussing Big Mouth and its use for research. We have 4 excellent presenters today. We have Dr. Mohammed Walji, who is the Associate Dean of Technology Services and Informatics at the University of Texas Health Sciences Center at Houston. Then we will have 2 presenters who will talk about strategies for analyzing Big Mouth. Udo Oyoyo, he is the Director of Statistical Services at Loma Linda University School of Dentistry, and Alpha Ibrahim Yansain, he's an assistant professor at the Department of Preventive and Restorative Dental Services at UCSF School of Dental Medicine. And last but not least, Britta Magnuson, who is also an assistant professor and assistant director of biostatistics and experimental design at Tufts University School of Dental Medicine. Welcome, everybody. We will go through all the presentations and do the questions in the end. So please send all your questions in the chat box, and I will monitor the chat box. And please keep your microphones mute. We are recording this, and we will also make sure to provide you the recording later on. So thank you, and I'm going to mute myself, and Dr. Walji, if you can share your screen.
Great, thank you, Dr. Tiwari. Can you see my main screen here, the PowerPoint?
Yes, I can see it.
Okay, thank you. So good afternoon, everyone. It's a real pleasure to be able to be with you. And thanks again to Dr. Tiwari for inviting us all to talk a little bit about the Big Mouth Dental Data Repository. So this is a repository that was initiated, from a meeting probably back in 2007 at the Tufts School of Dental Medicine, where a group of, essentially it was faculty and staff from dental schools that got together who used the same electronic health record called Axiom. And this is where this consortium of oral health research informatics actually started. And so we had this idea that maybe we can do a little bit more. Obviously, a lot of work has been put into collecting data in the electronic health records. Lots of assessments, a lot of time clinically, and it's so critical. but what if we could use that data for secondary purposes, such as for doing research? And so that's where kind of that idea germinated from. So before we kind of get started into the formal presentation, I just wanted to get a sense from the rest of you guys, why are you here today? What would you like to use BigMouth for? So if you can just take a second and just in the chat box, if you're able to just put in your thoughts, anything you're willing to share, and that will just give me a little bit of an idea of, the things I might want to cover when I do the demo in a minute or two. So while people are putting it in, I tell you a little the research that I'm personally involved in using data from BigMouth, and that mainly focuses on looking at quality and safety of oral healthcare. So I remember one of the things I first looked at BigMouth is that we have all this data, especially a lot of nicely coded procedural information, but we didn't really much of a diagnosis information, at least that was standardized and structured really well. So I remember this team at Corey, motivated by that desire, developed a diagnosis terminology that is now being used by many of these dental schools. So just looking at the chat box, I can see exploratory studies, outcomes research, perio, record and medical history mining, medications in dentistry. Okay, great. Looking at disparities, outcomes again. Yeah, and so somebody mentioned student research here as well, and I hope we have some trainees on today as well, because we do find that this is a useful tool to help train our students in scientific thinking as well as many residents as well. Oral cancer screening. Okay, great. So I think that gives me a really nice idea of what everybody is interested in. So let me give you a quick background. I mentioned, this kind of idea germinated back in 2007 in a group of 4 different individuals from these 4 dental schools. It was Elizabeth Kalandarian, who was then at Harvard. She's now at UCSF. We have Joel White at UCSF. Tufts. Before Britta came on board, we had Paul Stark, and then myself at UT. And we were fortunate enough to write a grant at the National Library of Medicine to kind of seed this idea. And we were able to get 4 of our dental schools' data together, and we were able to have about 1.1 million patients in there. In 2014, we were fortunate to get University of Pittsburgh also onboarded. By that time, we had a better idea on the process, how we can extract data in a meaningful and privacy-preserving way. And we're able to get up to 1.6 million patient records. In 2015, we brought on Michigan, which was really exciting. You can see the great jump in the number of patients, once Michigan joined in 2015. And then in 2017, we had Colorado. The host for our webinar today, and we were able to add another couple of 100,000 patients. And then in 2019, we had Loma Linda joining, and Udo will be talking a little bit about the statistical side, who's at Loma Linda. And then in 2020, although it's been a strange year, it was a good year, at least from the BigMouth perspective, where we're able to get both the University of Buffalo and Iowa School, College of Dentistry, who's just joined our database, and their data has been in there since September of this year. So we're now up to about 4 million patient records. If you kind of look at this chart or this map, we have pretty good representation across the US. In Corey, this consortium of oral health research informatics, I think we have about 40 or 45 member institutions. So a long way to go. We're really excited that the next university that's coming on board is University of Minnesota. We hope to onboard their data very soon. So now I want to kind of dive straight into the demonstration. And I'm going to hope the technology works here. So let's see, hopefully you guys can see my web browser. So this is the website that we have. It's bigmouth.uth.edu, and you guys can go in there right now. So when you log in, you can kind of see the institutions on the left. And if you have not yet logged in, I know many of you who are attending today are at one of our participating institutions. So you guys have the ability to access BigMouth, and I'm going to show you a little bit what it would look like. But if you're interested, you go to access BigMouth, choose your institution, and you kind of follow the instructions that are listed. You know, I'm obviously signed up, so I'm going to click here to log in. And what we've done is we've been able to use the same login systems that you guys use at your own institutions to be able to log into BigMouth. So I would normally just put in my username and password at UT in order to do this. And let's see, I feel a bit like Bill Gates here when he used to demo Windows and everything crashed. So let's see what the problem is here. So I'm logged in here. Let's see if I launch the client, whether it lets me in. So while this is loading, BigMouth contains data, and you can see here that it's working. So I'm just going to hit login. So BigMouth contains data from our Axiom instances at each of our institutions. Now, when you log in, this is what you will see. I'm logging in as an administrator, so it's a little bit different. So when I open up this Axiom folder, I'll be able to see all of the universities, but that's not normally be set up. So if I'm a UT Health user, I'd only be able to see the UT Health data, and that's all I'm going to show you today. So if I'm a UT Health user, I can see that I have about 407,000 patients in my instance over here. I'm going to try and make it a little bit bigger. So I'm not sure how it's showing on your screens. And this is the type of information we have in there. We have demographic information. So we've got 407,000 patients with demographics. We've got 96,000 patients with diagnosis information. We also collect, lots of information in the forms like the medical and dental histories. We have, the type of insurance the patient has, medications that are being prescribed, as well as the current medications that are being listed, information on the odontogram, the perio chart. If you guys have set up your Axiom to have different practices, like we have a faculty practice and graduate practices and student practice, we're able to search through them. And then we've obviously got the procedures as well. Now, when we developed BigMouth, it was really important for us to make it so that a faculty member or a resident or a student who may not be an expert in querying databases should be able to do some quick searching. So let me show you how that works. So let's say you are interested in Kerry's risk assessment. So one of the things that, as part of the diagnosis terminology that was developed, we have listed information on caries, for instance. Now, obviously, you can put in a caries diagnosis, but I'm going to just show you that. Let's say if you are interested in finding, okay, give me the number of patients that we have a diagnosis of high risk. Now, I know there's debate, is this really a diagnosis or not? The decision was made is that, we can code this as a type of finding or a type of diagnosis in this terminology. So let's see over here, you can see that at UT, I've got about 9,000 patients who are at high risk for dental caries. And all I do now is drag that into this box here in group 1. And if I hit run query, I can find out a little bit more about these patients. I can find their gender breakdown as well as their race breakdown. So let's see if this is able to return those results. So you can see here at the bottom that it's executing the query, and you can kind of see the male-female breakdown of these 9,000 patients that we have split, 50-50, I would say, a little bit more female. And then we have kind of the race breakdown of the patients. And what we've found in our databases, we have a lot of unknown because the way information was collected, especially in the past, which is a challenge. So let me show you a little bit more of a specific search. So now let's say that you say, okay, I also collect caries risk information in a specific CRA form at my institution. So I'm going to go to all of the forms that I have at UT, and there's tens, I think there's dozens of forms. And so I'm going to find the caries risk assessment form. And what I will do there is I'll find a similar concept like high risk dental caries, and I'm going to drag it into the box here. Now, one of the things I wanted to show you is when you drag something in another box, it's kind of like a Boolean operator. When you've got, I want to look at high risk for dental caries, and I want to see how many patients had a sealant instance. So I could drag sealant into group 2, and that would give me the intersection of those. But now let's say I wanted to drag some more information about caries risk assessment. So I can see that I've got a caries risk form, which has been filled out for 15,000 unique patients. And I'm going to go right to the end of the form, where the actual risk level is selected. And I'm interested in just high. So I'm going to add that in here. So now it's saying, give me all patients who have dental caries as a final diagnosis. And then also that indicator is there as well. And actually, I made a mistake here. So I'm going to remove this. Because I'm going to delete this and I'm going to say yes to high risk. Because if I had selected this folder, it would find me anybody who's actually answered yes or no. So I'm just going to go here, yes to high risk. And you can see that there are about 10,000 patients here. And actually, I'm going to do that right now. So this basically tells me that there are this many patients who have either high risk caries, either as a diagnosis or as a form. And let me hit that right now. And then while that's running, I now want to know of those patients that come back, how many have actually had a sealant? So because maybe you're interested in seeing how well are we doing, I'm interested in quality. So how many of our patients who have high risk for caries actually have had a sealant placed? So all of you guys know that we can look up sealants by going into the procedure terminology. And if I explode the procedure terminology, and it's taking a few seconds, while it's doing that, you can see that there were 7,000 patients that were have these characteristics. So now let me open up the CDT procedure code. And I'm going to find the preventative side. And I'm going to go to 1351 because I think that's the sealant code. And I'm going to drag that sealant code into this group 2 box over here. So here's the 1351. And so now it's going to give me information on, I'm interested in completed procedures only. It's going to give me information on, what's the intersection? How many of those, I think it was 19,000 patients that had actually a sealant in there. So while it's running that query, I didn't have time to go through all of this, but basically we also have information that you could do the same type of search, not only at your own institution, but across all the institutions as well. And what we do is we preserve the privacy. So you can't search for an individual institution, but you can search across everybody without knowing where the information comes from. So you could do that exact same search across this Cori network as well. And you can see about 4,000 of those 19,000 patients had a sealant. So that's just giving you kind of a taste of what BigMouth is able to do. So I'm going to quickly just go back to my slide deck. Okay, and this table here just kind of gives you a summary of the amount of data we have, and these are unique patients. So you can see we have nearly 500,000 patients with diagnosis information in a structured way, which is pretty exciting. Some of you are interested in medications. We have captured lots of structured medication data. So if you wanted to do a search on how many patients have an opioid prescribed or antibiotic prescribed, you would be able to do that pretty easily. So how can you guys get access? I showed you that website before. You just go ahead and register for it. And then once you've registered, you can actually get level 1 access, which is basically what I showed you right there. You can do all of that querying yourself and basically see whether you have enough patients there in order to propose a detailed research project. And if you'd like to do that, you would just essentially, you'd make sure that you have IRB approval from your institution, and then you submit your proposal request to a committee that's made up of a member from each of our 10 institutions right now, soon to be 11. They evaluate it, and once it's approved, you work with our data analyst, Krishna, and he'll work with you to get the data out of the system. So it's really pretty simple. And just lastly here before I end, we're also working in the future on how can we combine both data from our electronic dental records as well as our medical records. And this just shows you some preliminary work we've done at UT to find the overlap. So we're hoping in the future, especially if we can get buy-in from all of our institutions, that maybe we can include the medical information for our dental patients in BigMouth as well. So with that, I'm going to end. Thank everybody for your attention. Before I hand it over to Udo and Alpha, just quickly, if Dr. Tiwari can open up the poll, do you guys think that BigMouth can meet your needs? You put in at the beginning some of the research requests. With your brief kind of review of this, what do you guys think? And while you're filling that out, I do want to acknowledge Krishna Kukul and Joseph Applegate from our technical team. Krishna is our technical lead for BigMouth, and he and Joseph have been doing a lot of hard work. Also, many thanks to the contributing sites, for participating in all of this and helping us develop BigMouth, and also to NLM and NIDCR for funding as well. So I'm just looking at the poll results, and I see a lot of, pretty much split between yes and maybe. So obviously you guys need more information, and I'm gonna turn it over to my colleagues for their presentation. So let me go ahead and stop sharing.
Alpha, you're muted.
Okay, so I'm gonna start sharing just now. Sorry, just a second. Can everybody see my screen?
No, we can just see your desktop, I think.
Okay. Okay, how about now?
Yes.
Thank you everyone for your patience. My name is Alfian Sane. I'm an assistant professor at UCSF, and I'm presenting with Udo Oyoyo, who's an assistant professor at Loma Linda University. Both our backgrounds are in statistics, and today we're presenting our work, or some strategies for analyzing EHR data. So using it is the hardest part. So most often the big data, using big data effectively is the biggest challenge. What can we do with all of this data? And how do we get actionable information from it? Well, in many cases, BigMouth has made this easier for users. So BigMouth has connected several dental institutions with which Dr. Walji spoke about, and they make use of the same EHR. This allows users who seek to do research to perform simple queries for studies that interest them. And the use of data derived from the EHR is definitely a growing area. And EHR exploration allows researchers to study disease onset, severity, progression, and information is readily available for demographic variables, health behaviors, vital signs, in and outpatient visits, and medications. So hopefully by the end of this talk, we can arm you with some strategies that will help you design your study using the BigMouth data repository. So both Udo and I will be switching between slides and explaining the presentation. So please continue, Udo.
Thank you, Alpha. One of the primary objectives of clinical research is gaining knowledge from evaluating or studying a subset of patients. And from that subset of patients, we can then apply what we've learned to a much wider group of patients. And the goal is to improve care eventually. But in routine practice, patient care is delivered within a very rich background of intrinsic and endemic confounding factors, biases, biases associated with practices, biases associated with patients. And so when we want to conduct research, our clinical research methodologies, they have a very big challenge, and they're challenged to, one, accurately delineate or accurately characterize the specific relationship we have a question about that hopefully is going to improve care. So in outcomes research, in epidemiology, clinical research, researchers are interested in measuring and assessing the relationship of an exposure with the disease and the outcome. And as our very first step, we need to define a hypothesis. And that's what we're hoping that we're able to emphasize for you. And that is, Big Mouth is great. It's a large data set, but even that large data set represents a sample of everyone who has been treated in these academic oral health clinics. And so what we want to make sure we emphasize again is that you need a question, some question that's been structured so that it acts as a hypothesis and can then focus you on what kind of study design would be suitable to address that question or to address that hypothesis.
So here we have the hierarchy of study designs piggybacking on what Udo was just speaking about. As you move up this pyramid, each step represents a differing approach to the design and the collection of data. And you have increasing levels of credibility going from the top to the bottom. So increasing levels of credibility are at the top, where more threats to validity of your data tend to be at the bottom. But each of these approaches, what their key functions are to help you to establish who does or does not have disease. Do the treatments actually improve the health status of your patients? So that's going to be one of your hypothesis questions, or it could be one of your hypothesis questions. How are new preventative treatment services evaluated for effectiveness? How are risk factors identified? What evidence is needed before you can actually make a causal, determine whether there is a causal relationship? Typically, researchers and public health practitioners are interested in the cause and effect relationship, which is presented at the top of the pyramid. But unfortunately, most of us only have a single shot to study, to conduct a study. And so there's benefit to finding study designs that are more tractable, that tend to be in the middle area, in the observational study area. As such, we want to focus on a lot of study designs that test observational data, because Big Mouth at its core is comprised of observational data. So here we'll go through some of the study designs. So Udo.
So probably the most important question that you want to start with when you're thinking about what study design is most appropriate is to consider the impact of timing. And so as you can notice on this figure, each of the study designs that Alpha briefly highlighted to us, the cross-sectional study design, prospective and retrospective cohorts and case control, and experiments or randomized controlled trials, they're here. What you'll notice too is that they've been sectioned off into three time points, past, present, and future. So one of the things that you'll notice is that for the cross-sectional design, its best use for you is for assessing exposure and outcome at one particular point in time. It doesn't necessarily mean that the exposure happened at that time or the outcome happened at that time, but for your assessment of those factors, it's at one point in time. So if that's what you're interested in, then a cross-sectional, or if that's what you're limited by, a cross-sectional study design is probably best for you. If, however, you have the opportunity to identify a cohort of patients and then follow them in time, and we would then need to speak to Krishna and those are over at UT to make sure that it's within the bounds of protecting PHI. But if you have that opportunity to follow patients over time, then the possibility for a cohort study, a prospective cohort study, is within realm for you. If not, however, you might want to consider proposing a retrospective cohort study design where we can look at the data that has already been collected. This would also, in terms of looking at prospective or retrospective cohorts, we would need to you would want to think about what your element of analysis is going to be. Is it the patient? Is it the clinic? Or some other larger unit? That also would impact not only your PHI, but what kind of data is available for following over time or for a retrospective review. Finally, the case control studies are those, again, that can be conducted for data that has already been collected, which we already identified as one of the unique features and advantages of the BigMouth data set. And then finally, for the randomized trials, they naturally are prospective in nature, but one of the limitations there is the inability to randomize patients to an exposure. If, however, this is data that is still being collected administratively, there is that possibility to possibly look at that data within BigMouth. But again, that would require a special kind of review from the BigMouth team to determine the likelihood of conducting a trial using BigMouth data. But again, to summarize, timing of your data collection is probably your first question that you want to consider when you're thinking about what study designs are appropriate for answering your question.
So as with most studies or study designs, there are disadvantages and advantages. So here we have aggregated all of the observational studies that Udo just was speaking of. And they have advantages in the sense that they're efficient, and for a myriad of diseases, both rare and not. They also are less costly and less time consuming. So they are advantageous when exposure data is expensive or even hard to obtain. And they also have advantages in studying dynamic populations where follow-up can be quite difficult. Some of the overarching disadvantages are that they're subject to selection bias. They are inefficient for rare exposures, and information on exposure is subject to observation biases. And they generally do not allow calculation of incidence. So here, I think one of the big takeaways is that when doing observational studies, making sure that you adjust for confounding. Now, depending on how well you're able to adjust for confounding, there may also be opportunities for you to establish causal relationships, even in an observational study, but those take much more advanced methods.
So far, we've done our best to try to very briefly, without a lot of time, introduce you to some of the typical study designs that are used when evaluating BigMouth data. These are the observational study designs, case control studies, cross-sectional studies, and cohort studies. But there are other levels of evidence that you're familiar with as clinicians or clinical researchers, and those would be, at the bottom of this pyramid, background information and the expert opinion, and at the top, systematic reviews. And we wanted to make sure that we mentioned that we are aware that the majority of clinicians rely on information from their colleagues. You have a question, you poll your colleague, and their response typically is treated as expert opinion. Right now, BigMouth does not have the capability to act as Big Blue or Siri, where it will take your natural language question and do an analysis and report back to you a natural language answer. But maybe Mohammed could speak to potential or future capabilities of BigMouth data being used that way. But one area that Alpha and I are actually quite excited about, especially for seeing, is at the top of the pyramid with the systematic reviews and more specifically meta-analyses, with data that's considered to be national data. That's the BigMouth data with over 11 institutions providing data there. There is the opportunity to take a question and then to sample nationally, looking at estimates and seeing how those estimates compare. much in the same way that you might do with a systematic review, where you take several papers, all looking at the same kind of exposure and outcome, and look at the reliability of the estimates, look at the confidence intervals around those estimates, and to come up with some kind of pooled estimate. So whereas the systematic reviews typically take as long as it takes for maybe 5 to 8 papers to be published, with the BigMouth data, you have this capability of deriving estimates regionally and then comparing them the same way you would with a meta-analysis. So there are other levels of evidence that feed into the decisions that clinicians and clinical researchers need to make. We just want to make sure that we pointed out that BigMouth data can be used creatively in these other ways to address some of the things that we've waited 10, 12 years for. You can do probably in less than a year with the right kind of proposal for the BigMouth data.
Great. So with that, I think also to summarize is that a lot of the questions that you tend to have that are feasible within BigMouth dataset lend themselves to the observational side, even though we are able to possibly to conduct some experimental studies. Observational studies are much more tractable within the context of BigMouth. So with that, we would like to leave you with a question of how many of you are looking to complete a project with BigMouth within the next 6 months. Dr. Tiwari, if you could post our question to take the poll.
I think I had a different question from you guys. So I would encourage people to just let us know in the chat box, or if not, they can also email us later on with questions if they are looking at a project in the next 6 months. I do have it.
I think the other poll question is important too. We'd like to know how many of you are considering, what kinds of study designs you're probably most likely to propose using BigMouth data.
Yeah. Wow, so it looks like several of you are looking to do retrospective cohort studies, followed closely by cross-sectional study.
Excellent. Those are the low-hanging fruit of what's available within BigMouth. And again, some of the estimates that you get from these larger databases, they're fantastic. We still have to give consideration to threats of validity and bias, but again, that's the low-hanging fruit. These cross-sectional and retrospective cohorts, got to go for it.
Great. Okay.
Excellent. Thank you so much for being patient and participating with us in this part of the presentation. We ask that you would then direct your attention to our next speaker.
Thank you very much, everyone.
Okay. So hi, I'm Britta Magnuson from Tufts, and I'm going to piggyback on what Mohammed, Alpha, and Udo said and go a little more into detail of how you can use BigMouth to answer a study question and give an example of what you might look at. So share my screen. Okay, is that working?
Yes.
Okay, great. So my first poll question for everyone is, have you ever accessed the BigMouth database? So Tamana, can you launch that question? Is it launched?
Oh, no, it's just not. I can't get out of the earlier question.
Oh, here we go. Okay.
Here you go.
Okay, looks like very few people have done that. So great. So you saw the demo that Mohammed had, and I'll go a little more into that and exactly how you can access the data, which he touched on, but I'm going to go a little more into detail so you know the process. So accessing BigMouth, you saw the link that Mohammed went to, and I'll go into in a few minutes, and you download and complete a data access request form, which I'll show in a minute. And when you go in there, you pick your institution. So I would pick Tufts, or someone else might pick Iowa. And from there, there's the contact person that you send the data access request form to. And then you do an online registration through the BigMouth database, which uses your user login and password from your own institution. And then Krishna will give you access. It's very simple. It's pretty quick. The access request form is basically saying, I understand the data is confidential, it's de-identified, I won't share it with outside parties. Just kind of your understanding of how to use the data that you'll be accessing. So like I said, this will go to your representative at your school, and at the end I'll have a list of that. And then you go through the website and register. So Mohammed touched on the 2 levels of access, and the one we've been showing today is level 1 access, where you can run your queries yourself and use the counts, and you can review overall numbers, and you can see numbers specific to your institution or for all the BigMouth institutions. Then if you want to go forward and do more of a design study like Alpha and Udo talked about, and want to actually put together a study design where you need more data collected, you go through level 2 access. And that takes more information is required in order to get that data. So the project or proposal will need to be reviewed by the Corey Project Review Committee, which has a representative from each school, and then it has to go through your local IRB before the data can be obtained. So you may be wondering about the review committee. We meet monthly, and we look at proposals as they come in, and you can expect to have feedback within 4 to 8 weeks of submitting a proposal. Most of the time we have questions and might ask for clarification, so there might be some going back and forth between us and you about what is needed for the proposal, what questions we might have, but that's the process, and we're happy to give feedback. We do request that the proposal comes in a certain format, and that it has these sections. Now, if you've run a research study before or written a protocol, these sections will be very familiar to you. Just going through your whole study design. So principal investigator would normally be a faculty member at your institution, and co-investigators could be students, residents, other faculty member. And then we really want to see how you think what you're adding to the research literature is significant and what might be new about your project. Preliminary work and data. I saw someone mentioned in the chat that they've done work with their own Axiom database, and that's really great to put in as preliminary work and data. You can say, at our school we looked and found this, and now we want to expand to BigMouth, so that's a great place to put that kind of data. Your specific aims and hypothesis, we want to know exactly what you're looking for, your hypothesis that you've generated, what question you want to answer, and your research design and methods. So this will include what variables you're looking at, your statistical plans. So we like to make sure you have an analysis plan for how you're going to look at the data and how you're going to run the numbers once you have it. Also, preliminary sample size calculations. This is important because we want to make sure that the BigMouth database has enough information for you to do your study. So this can be done. And then these other sections that are more deliverables and dissemination, what you plan to do with it, alternatives of what you might be able to do, acknowledgement of using the Big Mouth database, and then references, and we'll talk about the IRB and the data release letter. So these sections all go into it, and there is a template on the website that you can find that has this, and then you would submit that. So you may be wondering about the data, how it's shared at the institutions. In each institution, there's a data use agreement already in place. So the data is being shared from each institution with UT. A general IRB of approved protocol is also in place for Big Mouth. So each institution is operating under an IRB approval or institutional review board where they're saying, yes, this data is being sent to UT and this is how it's used in general. However, each study where you want to request this level 2 access will require a specific IRB approval at the local institution. So generally, once the committee review has happened and it's in good shape and as we think it's ready to go, we would make sure that you also have IRB approval at your institution, and then it could go to UT where they'd be able to extract the data for you. So there's a template that goes along once you know what exact variables you're going to look at, and this helps the data team at UT know exactly what variables you want collected. This is important too, to make sure you look in Big Mouth ahead of time and make sure what you want to look at is actually there, because sometimes we see proposals come in and there might be an example of a variable they want to look at that isn't within Big Mouth. So maybe they need to change that variable, think of a different way the question can be answered. So you can really explore in Big Mouth and see what's in there first. And then UT will collect the data and it's sent securely. It's sent through a secure link. And the length of time for data extraction will depend on the complexity of request. So really how long the process takes just depends on how well the proposal's written when it comes, how ready the study's ready to go, how long it might take with your IRB, and then how complex the data extraction is. So more complex ones would take longer. So here's my second poll question. Have you ever conducted your own research study? Yes, as a student or resident, yes, as a faculty or staff member, yes, as both student and faculty, or no? Can you launch that, Tamana? Okay, great. It looks like most people have conducted their own research study. So then you'll be familiar with how I mentioned coming up with a proposal and how you go through that process and come up with a study idea. So, okay, I'm going to give an example. I'm going to give an example of a question that you might have to look at the Big Mouth. Some people, one of the questions we might look at is how many patients have chronic periodontitis? What percentage of patients reporting they have diabetes also have a diagnosis of chronic periodontitis? And that's important to know that the medical history within Big Mouth is self-reported. That's self-reported medical history information. It's not coming from a medical center or anything like that. It's what's been reported at the dental school. And then what percentage of patients reporting they do not have diabetes also have a diagnosis of chronic periodontitis? So these are some questions we could ask. So are you able to see the Big Mouth? Yeah.
Yeah, I can see it.
Great. So here's the screen that Mohammed showed you and access Big Mouth. Here is how do I access Big Mouth. This is where you would go if you want to get that data request form and see who your contact is, but I'm already registered. So I'm going to log in and this will show you, it shows my Tufts user name and password. And this would be whatever your institution's is. So it's very simple. You don't have to remember another password. And here, from here, you launch it. And here, like Muhammad said, it's a little different for me because I'm not at the end, I'm an end user. So my Axiom database just shows Tufts. His showed every school individually, but mine just shows my home institution. So depending on what school you're at, you would look at that. But I'm going to look at the Cori data where it has all the data for all the schools. So if I want to look at periodontitis, I can go to diagnosis and then periodontics and chronic periodontitis. So I'm going to choose to look at generalized moderate, generalized severe, and generalized slight. Of course, you could do each individually, however you want to do this. And I can run the query and see how many people have this one of these diagnoses in here. And I'm going to break it down so you can see by age and gender too. Sometimes it takes a little while. All right, so you can see here's our total number of patients with a diagnosis of one of these chronic periodontitis diagnoses. And here's the breakdown. And like Muhammad said, the race is a little less reliably collected, so that, you know, hopefully, I know a lot of schools are moving towards collecting that more reliably, so hopefully over time that gets better. So, okay, then say I want to add in the medical information. So here's the forms. Now, every dental school in Big Mouth is using a common medical history form called the Cori Medical History. And that was established by several Cori members as having the basic information that we think everyone should be collecting. Every school then does add questions to it, as they may have specific questions they want to ask more about. But that is, everyone's has this basic data. So say I want to say, okay, how many have this diagnosis of chronic periodontitis and diabetes? You can see here the total yes with diabetes is 31,537. And I'm going to run the query again. And here's what we get for an answer for number of patients. So now I'm going to, we could run this query again with no, and I won't do that for sake of time, but I'll show you the results. So we saw the total chronic with periodontitis was this. And then when I did yes with diabetes with periodontitis, I got 2804. And no diabetes with periodontitis, I got 12651, which I didn't show you the actual query, but it would be done similarly. And here's our total with diabetes and our total without diabetes. And then just doing a little simple, like, back of the envelope map, we can say, you know, if we divide these numbers, we see, looking at this really raw numbers, that 8.9% of patients who reported having diabetes had chronic periodontitis, whereas 7.3% of patients who reported not having diabetes had chronic periodontitis. Now, it's hard to really know what this means. This is something you can, you know, I look in the Big Mouth database sometimes and just run different numbers just to kind of get ideas of what, you know, what projects you might want to do, because it's interesting if you see something. So then you would say, this is of interest to me. So you would think about what type of study design, like Udo and Alpha said, would be able to answer your question. Would you do a case control? Would you do retrospective cohort? How would you look at it? It would most likely be observational in your first round looking at this information. And you might be wondering, is there a statistically significant difference between these groups? You know, one looks slightly higher than the other, but is it really statistically significant? What are the confounders? That was discussed in Udo and Alpha's talk too, just about like what confounders might be involved leading to these numbers. And you would think about what variables you want to look at. And what's interesting is all the periodontal parameters and all the odontogram information is within Big Mouth. So you may not see it on that query format that I showed it, but it's all extractable. So if you want to have the bleeding and probing for these patients, that can all be extracted. So these study questions can be answered by putting together a proposal and requesting the data. And it's really a simple process to go through, and we're here to help you. And these are the contact people at each of the schools that are represented in Big Mouth. So I'm all set. If we want to, if anyone has questions for any of us or wants to put them in the chat, or I think Tamana's monitoring that.
Yeah, I've been monitoring and there have been a few questions. There was one question that came just after Mohammed's presentation, and it was like, can we export the data with all variables?
So the answer is no, and not in when you do the level 1 access. You know, when what Britt and I showed the interface, you can't extract all the variables there. So again, what we're trying to do is to give access to you guys without having to submit a separate IRB, just where you're just getting a sense of the data. If you do, once you have a sense of the data and you want to extract the row level variables, you would need to go through the level 2 access Britta went through.
Then there was another question, how BigMouth data captures the medication history.
Yes, so good question. So from my recollection, medication history is an axiom. It depends how it's set up in axiom. But for instance, here at UT, we obviously have the prescribed medications. We don't use electronic prescribing yet. So whenever a medication is prescribed, it's prescribed as structured data through the medication module. But you can also have structured data to capture a patient's current medications. So as long as it's not in the clinical notes and it's actually put into the medication module, we're able to extract that data into BigMouth. Now there are issues because how institution X and institution Y recognizes that medication, or the terminology that they use may differ. So it does get a little bit challenging, to combine that, because we're not very good yet in dentistry of using standardized terminologies, even though there are things that exist for medications.
So there was a follow-up question on the level 1 access and whether that level 1 access is for all schools' data, or is it limited to just the school that the person is affiliated to?
Yeah, good question. So it's kind of the access that Britta showed you. So when Britta logged into Tufts, you could see all the data for just at Tufts. But then Britta also showed you the Cori, and Cori essentially is trying to get all the data across the 10 institutions together, and you can search across that data set. But you just can't identify where is that data coming from. All you know is it's all of the data in the pile.
There was another question about how to address issues such as missing data are handled in the summary statistics.
Maybe Alpha or Udo, if you guys want to take that.
Yeah, missing data is always an issue. I mean, if you're closer to 30 or 40% missing data, then I would probably not use that as inferential data, maybe just hypothesis generating. Getting closer to, you try not to get more than 10% if you really want to have accurate data. Having said that though, there are imputation methods to be able to handle missing data, to kind of see how robust your results are, and also to conduct sensitivity analyses as well too. But you'd have to talk to the BigMouth team to kind of find out to what degree are you missing data. Is it 10%, between 10% and 40%, more than 40%? And that'll give you an idea of what approach you want to take for how to handle the missing data.
Yeah, if I could just follow on.
Yeah, sure.
Sorry, and because I see another chat which is related on kind of validity of the data. So it's all, so basically we didn't talk today about data quality, but obviously you can think of quality in terms of how complete the data is, how accurate it is, and how consistent it is. We do a little bit of quality checks once we get the data in, but a lot of the bulk of the work actually occurs once somebody submits a project, the level 2 access. And that's when we really discover all the nuances of the data. So that's when we can, work with the researcher and say, okay, yes, this is how complete the data is. How do we really know, is this really accurate? Is there other ways we can validate that in terms of consistency as well? So it definitely is a challenging thing, but it's also a virtuous cycle. So once we find that there are quality issues, we then try and make sure that for the next request, perhaps from the site level, data can be collected a little bit differently to make sure that quality is improved.
Thank you. Another question, there were two questions which were about how often it is updated, the data, and what is the time frame of these data, like how, since when they have been collected.
Yes, so we update it 4 times a year. So every quarter it was updated. I think the last time was September, beginning of September.
Mm-hmm.
In terms of how much data we essentially have all the data that's in the institution's Axiom EHR. So for instance, at UT, we have all the data back from 2006 when we implemented Axiom till now. So it kind of depends on which institution you're at.
Okay, another question, is there a way we can know what research questions previously have been approved by query review committee? We wouldn't want to spend time generating a protocol for a study that's already been approved.
I think the answer is yes. Just contact one of us and we can probably look that information up and provide it.
Any more questions? There was a question about IRB application. I think Britta did answer that. The question was, where should the IRB application be sent? The IRB application needs to be sent to your own university. There is another question. There are 2 more questions. With respect to the query in level 1 access, what other information in addition to gender, ethnicity-based category can we get access to?
So that's pretty much it. So basically what you would do is, because it's basically a tool to give you counts of information. So whatever you put in those boxes, that what Britta and I showed, so you can create a pretty elaborate query in those boxes, and then it will just spit out, okay, these are the number of patients that are associated with that query. And then we do just break it down by race and gender currently.
Mm-hmm. If you're able to answer questions based on the query just in level 1, I assume we use the parent umbrella IRB approval when reporting the results. Am I correct?
Britta, do you want to take that?
I think this would depend on your institution a little bit, what the IRB thinks about this. I know if we're querying any type of study design, any type of study going on at Tufts, it has to go through a department or IRB review. So I think it might depend on your institution, how they oversee research being done at your school. Yeah.
There was another question. Can you share your PowerPoint presentation? Yes, I will. I'm recording this webinar and will have it available. Please email me. I will just put my email in the chat box and I will be able to share it with you. Another question, can anyone from the participating institution have level 1 access, or is it just a single representative from each institution?
Britta, do you want to take that?
Oh, yes. Anyone from the institution can have access. Here at Tufts, I've presented this outside the dental school. It can be anyone at the university. It doesn't have to just be within the dental school. So anyone who has that university login for one of the 10 institutions can have access. Just going through that, submitting that form and doing the online registration.
Thank you so much. And I am so glad we had so many questions, and I can see there are many people who are interested in this repository. And another question, is there a code book for this?
Yeah, so the best way to do that is actually looking at, getting level 1 access, and you can kind of get a sense of the data there. We do have a data dictionary. But what I would suggest is look at what's in there, because the data dictionary is sometimes a little bit tougher to maintain because of the heterogeneous nature of the data.
Okay, thank you. In the interest of time, I think I'm going to close the webinar, but please feel free to send us more questions, and I will have the recording for everybody to view later on. Thank you to all the speakers for taking out the time and giving us this valuable information.
Thank you.
Thank you.
Thank you, everyone.